Bismillah ar-Rahman ar-Rahim. The talk of today will be about the anion gap and corrected anion gap. So this is anion gap. We said anion gap. We did not say cation gap. It is an anion. Because to start with, I think we when we talked before that there is some sort of electron neutrality. The cations in the body, in the plasma, equals the anion in the plasma or the extracellular compartment. So the cations equals anions 153. If you sum of them up, 153 milliequivalent, and this is also 153 milliequivalent. This is the cation and anion, but usually we do not routinely measure all the cation and all the anions. But the routine measurements usually is sodium and sometimes potassium. Potassium usually is added, but the common here is sodium. This is the largest cation present in the extracellular compartment. When you look at the anion, we usually measure the routine is bicarbonate and chloride. We do not measure the phosphate, sulfate, protein. All of these are not measured. So what we measure is the in the anion, this is the bicarbonate and chloride. And in the cation, this is usually sodium. When you look at the sodium, it forms about 142 milligrams per liter. When you come to the bicarbonate, it's 24 and the chloride 106. These two together usually they form 130 milliequivalent, and this is a sodium 142 minus 130 gives you 12. This 12 is not this is a positive cation and this is a negative cation. This is not the difference between this is a positive. No, it is a negative because this is 12 should be added to 130 to equal 142. So this is that's why this is the anion gap. This is a gap. It is an anion. It is an anion. This is a difference in the anion. This anion should be added to this anion in order to equal that cation. So that's why it is an anion gap. And just to make it easy, this is a sodium minus bicarbonate plus chloride gives you 12. This is a normal anion gap. This normal anion gap usually look at the changes. Sometimes the sodium increases, when the sodium increases as when we add say sodium acetate or what we call ring acetate or sodium acetate, we know that dissociates into sodium and acetate and dissociates into acetic acid and hydroxyl groups. This leads to alkalinizations of the media or alkalinizations of the blood. So this is when you add sodium acetate, so you are adding sodium. Suppose you added 4 milliequivalent sodium and 4 milliequivalent acetate. What you measure routinely is sodium. So the sodium increased instead of being 142 became 146. But on the other hand, this is a bicarbonate the same 24, chloride the same 106, the two together 130, 146 minus 130 gives you 16. So this is larger than the normal, which is 12. So this is a case if you added sodium acetate, so you will produce what you call high anion gap metabolic alkalosis, because sodium acetate will give you alkalosis, will give the pH will be alkaline. So this is the first change. You can notice that increasing the sodium itself, like sodium addition of sodium acetate, will be will give us high anion gap. This is that's it, metabolic alkalosis. Another important point in cases when you look at we mentioned before that there's some sort of electron neutrality between the total weak acid, which is a protein and inorganic phosphates, and bicarbonate. Decrease in the protein will be associated with increase and concomitant increase in the bicarbonate. The two together, this is in total weak acids forms about 16 milliequivalent and the bicarbonate 24. The two together form 40, which is the buffer base. We are going to talk about it later. So this is a decrease in the albumin will be associated with increase in the bicarbonate. And we mentioned before that decrease in the albumin by 1 gram will be associated with increase in the bicarbonate by 2.5 milliequivalent. So this is a very important point. So this, if the patient is having hypoalbuminemia, this will be associated with increase in the bicarbonate. Instead, say of 24 to be 30, something like that. If you, but no change in sodium. Sodium is 142 minus 30 plus 106. This gives you 6. So in cases of hypoalbuminemia, the the anion gap in this case will be low anion gap, and the low anion gap was high bicarbonate. So this is a hypoalbuminemia will be associated with metabolic alkalosis and the low anion gap, and this should be considered. And we're going to make some hint about this is for when we talk about the corrected anion gap. So these patients, if the patient, imagine that this patient is a patient with hepatic liver cirrhosis and is having hypoalbuminemia. In this case, when you look at this patient, the bicarbonate will be high, albumin will be low, and the anion gap of this patient will be low, and the patient is having metabolic alkalosis. This is the standard of this patient. This patient develops some sort of problem like metabolic acidosis with decrease in the bicarbonate. In this case, the anion gap in this case, instead of being 6, may be 10. And this 10 is below the normal, the standard, which is 12. But this patient, the standard of this patient is 6. 6 to be 10, this means that he's having high anion gap metabolic acidosis because his standard previous state was 6. Again, this is the second part. So hypoalbuminemia will be associated with low decrease in the anion gap, and this is metabolic alkalosis. The third part, which is normal anion gap but metabolic alkalosis also. So metabolic alkalosis. This is a look at this. This is a patient is vomiting. He's losing a chloride, but at the same time gaining bicarbonate. This is the electroneutrality we talked before. Loss of percarbonate or chloride from the gastrointestinal tract or the kidney. This will be associated with concomitant gaining of the another molecule. Loss of chloride will be associated with gain of bicarbonate. Loss of bicarbonate will be associated with gain of the chloride. So the two together will be 130. There will be no change. So if the patient is vomiting, he's losing bicarbonate and losing chloride and gaining bicarbonate, but the two together is 130. So 142 minus 130 is 12. So this is a case of metabolic alkalosis, but normal anion gap. So this is so we have seen that metabolic alkalosis was high anion gap, low anion gap, and normal anion gap. When you come to the second part, which is metabolic acidosis, this is the most common one. We usually talk about this. We do not talk about the alkalosis in this way, but we have to remember it. The metabolic acidosis. This when we look at metabolic acidosis, is it with high anion gap or normal anion gap? In this case, this is a normal anion gap. Metabolic acidosis, this means decrease in the bicarbonate. Decrease in the bicarbonate. The patient is having diarrhea, is losing bicarbonate, but at the same time gaining chloride. And we have mentioned before, this is electroneutrality. So loss of bicarbonate will be associated with the concomitant increase in the chloride, and the two together will be 130. No change in the sodium, so 142 minus 130 gives you 12. 12, this is a normal anion gap, is 12, but this is metabolic acidosis. So this is diarrhea will be associated with loss of bicarbonate. This is metabolic acidosis, but concomitant increase in chloride with no change in the anion gap. Same like this, look, this is a high anion gap. What's my high anion gap? This instead of being being 12, it is 20. High anion gap. This means that the bicarbonate itself decreases, and this decrease in the bicarbonate is due to addition of some other acids to neutralize part of the bicarbonate buffer. So the bicarbonate, like lactic acidosis, ketoacidosis, in the case of diabetic ketoacidosis, or strong acids like in cases of renal failure. So this will react with bicarbonate, and the bicarbonate decrease. So there is a decrease in the bicarbonate, no change in sodium, no change in chloride. the two together, if you add this to that and minus 142, you will find that there is an increase in the anion gap. So increase in the anion gap, for sure, this will not happen except when some sort of acid has been added to neutralize the bicarbonate. This is very important. Normal anion gap, there should be the pathology through the gastrointestinal tract or the kidney. But here, this is anion gap. This is lactic acidosis. Part of the bicarbonate decrease, instead of being 24, became 15 or 16 in this case, and they neutralized by 10 lactic acids. So this is we do not measure that. We measure bicarbonate and chloride. This minus that gives you. So this is a high anion gap metabolic acidosis. The same like that. When you look at this is the DKA patients, the beta ketone bodies. This is a ketone, keto acid, beta hydroxybutyric acid, and acetoacetic acid reacts with bicarbonate. So this is the part of this bicarbonate now it has been changed. Part of it is bicarbonate and the other is sodium acetoacetate, sodium beta hydroxybutyrate. So this is no change in sodium, no change in chloride. The bicarbonate itself decreased and replaced by keto acids. So this is a high anion gap metabolic acidosis. This is a case high in NGAP metabolic acidosis, which we said before. Sometimes in the treatment of these patients, you give him saline. Saline, this will not make a large change in the sodium, but it will produce a major change in the chloride because saline, the concentration of sodium is 154, and the chloride also 154. So this is a large chloride load. So the chloride increased, and instead of being 106, increased to 115. So this will add. So if you take the sodium minus the bicarbonate and the chloride in this case, might give you normal anion gap. But normal anion gap hyperchloremic, and this is metabolic acidosis still. So the bicarbonate is still low. This is the metabolic acidosis. It is a high anion gap, and this is added in addition to this of saline made it normal anion gap, and this hyperchloremic. Normally the ratio between chloride and the sodium will give you 0.74, but here increase in the sodium in the chloride load led to the ratio increase the ratio, and instead of being 0.74 became 0.8. So this is clue another clue for the hyperchloremia. This is a hyperchloremia, chloride to sodium ratio increased, and at the same time, this is the anion gap decrease. Instead of being a high anion gap decrease and came to normal in this case, and at the same time, still the bicarbonate is low. So this is metabolic acidosis. It was high anion gap, but addition of normal saline get narrow or normal anion gap and hyperchloremic metabolic acidosis. We are facing two metabolic acidosis, hyperchloremic metabolic acidosis and the metabolic acidosis from the DKA. Corrected anion gap. This is the problem when the patient is having, as I have mentioned before, hypoalbuminemia. Hypoalbuminemia will be associated with increase in the bicarbonate. And the ratio I have mentioned before, decrease 1 gram of albumin will be associated with increase in the bicarbonate, 2.5 milliequivalent per liter. So the basic state of the patient will not be, if we are talking about the anion gap, which is normally is 12. In such patients, it will not be 12. It will be less than 12. Say it will be 8. So when you calculate, when you take the decision that this patient is having high anion gap or low anion gap according to 12 or according to 8, no, according to 8. So they made the formula. This is a formula to see whether this patient is having high anion gap or normal anion gap after the pathology happening to this hypoalbuminemic patients. So this corrected anion gap equals observed anion gap you calculate it plus 2.5 normal albumin, observed albumin minus observed albumin. This will give you the corrected anion gap for this patient. Let us explain it in another way. This is a normal serum albumin 40 and this 40 gram per liter. To convert it to 1 milliequivalent, 2.5 gram of albumin equals 1 milliequivalent. 40 will give us 10 milliequivalents. So 1 gram albumin percent will give 0.2. 10 gram per liter give us 2.5. So this is the way. If the patient is having 2 gram percent, 2 gram percent means 20 gram per liters. So this is multiplied by 2.5. So this patient is, if the patient is having albumin 2 grams, the bicarbonate will increase by 5 milliequivalent. If the normal bicarbonate in this patient is 24, so this is here after the hypoalbuminemia, his normal bicarbonate will be 29. So this is normal for this patient. So the normal for this patient is 29. When you take the anion gap for this patient, which is 142, this is the sodium, this is the chloride, and here the bicarbonate which increased, so this will give us 7. So the anion gap for this patient is 7 milliequivalent. This is the standard for these patients. If this patient have anion gap, if he suffers some problems and you measure the anion gap and it became 12, this means that the patient is having high anion gap because his normal anion gap is 7. So the corrected anion gap for these patients, if you want to say what is the corrected anion gap for these patients, corrected anion gap, this is the anion gap, we measured it. This is plus 2 minus 2 multiplied by 2.5. This means 5. This is 5 plus this is about 12. So this is normal. So this is corrected. This means this as if this patient with 7 milliequivalent, 7 milliequivalent anion gap, as if he's having his anion gap after corrections of albumin, his anion gap would be normal. Take an example. This is a patient with albumin 2 grams and bicarbonate 20. So this is a patient with albumin 2 grams. His bicarbonate, the mean bicarbonate should be increased by 5, right? So the mean total bicarbonate for this patient would be 20 plus 5, 25. So this is patient bicarbonate should be 25 if we added the difference between these two. Anion gap 142 plus minus 16, this is a chloride, plus 25. So this patient, the anion gap of this patient should be 11. This patient, the anion gap should be 11. The standard anion gap for this, but this patient, if we take this patient, what is his actual anion gap? His actual anion gap with this hypoalbuminemia, that the anion gap, this is the sodium, this is the chloride, and this is the patient should have with hypoalbuminemia, the bicarbonate is normal, is 24. If we add 5, this is 29. So this is the patient should have a 29 bicarbonate. And so the anion gap for this patient should be 7. But here, what we measured here, the anion gap in such patient with bicarbonate 20, it is 11. So the patient is having high anion gap. By the formula we mentioned before, corrected anion gap equals the anion gap we have. This is anion gap plus this is the difference between albumin is 2 grams, 4 grams normal. The difference is 2 multiplied by 2.5. This gives you 5 plus 11. This 16. This 16 is more than 12. So this is high anion gap. So you can take it this way or another way. What is the normal for this patient if he is having nothing? If the patient just have hypoalbuminemia, the bicarbonate plus the difference will give you this is the normal, the standard for such a hypoalbuminic patient. This is the normal or standard anion gap. But his actual anion gap in this case, when we calculate it, is 11, so he's having an anion gap. Or make it this way. This is the anion gap plus the difference between the two give you 16 more than 12 by 4. This means that the patient is having this is a corrected anion gap. We have to take care of it. We are going to use it in a lot of things. Another way for this is the difference for the instead of taking corrected anion gap, this is what called delta ratio. Delta ratio means that this is the ratio, this is the increase in the anion gap, the difference in the anion gap over the decrease in the bicarbonate. And this, I think, you have to know it, but I think the previous one is a little bit more better than studying this or memorizing this. If the ratio is less than 0.4, this means that this hypercoloric normal anion acidosis. I think you'll forget it. If it is between 4.4 and 0.8, consider combined high anion gap and normal acidosis, but not that the ratio is often less than 1 in acidosis associated with renal failure. It is a little bit tedious and sometimes something difficult to remember. 1 to 2 usual for uncomplicated high anion gap acidosis like lactic acidosis, average value 1.6, DKA more likely to have a ratio closer to 1 due to urine ketone loss. If it is more than 2, suggests a pre-existing elevated bicarbonate level, so consider a concurrent metabolic alkalosis or pre-existing complicated disparate acidosis. This is a delta ratio if you can use it, but I think the corrected anagab is a little bit more easy to understand and more easy to make a comment. And thank you.